The breathing. The anatomy of the bronchial tree. During the inhalation phase, the rib cage expands and the diaphragm moves deeper. The volume of the lungs increases and it creates a vacuum, which lets air flow into the bronchial tubes. As the figure shows, the bronchial tubes become increasingly smaller. After 24 divisions, they end up in the air sacs, alveoli. The alveoli are, see red circle, connected by pores. The thin walls of the alveoli are shrouded by a network of tiny blood vessels, capillaries, that allow a rapid exchange of oxygen and CO2. When inhaling, the alveoli fill with air. The oxygen can transgress rapidly from the alveoli into the blood of capillaries via the blood-air barrier. At the same time, the carbon dioxide takes the opposite path from the blood into the alveoli and is then exhaled. The air sacs and adjacent bronchioles are covered by a surface film, known as surfactant, surface active substance. The surfactant reduces the surface tension of the alveoli. This will prevent the collapse of the smaller alveoli at the end of exhalation. In addition, the surfactant is a cleaning film, which glues all inhaled foreign bodies as well as viruses, such as in a fly trap, and removes them from the bronchial tree towards the mouth. In addition to the cleaning film, there are cilia. They transport the mucus through the applications towards the mouth. The production of the mucus and the influence of the cilia are precisely coordinated. Normally, the mucus does not accumulate in the bronchi. Also, the quantity of surface active substance preventing a gluing of slime with the cilia is adapted to this system. Damage of the bronchial mucosa. Cilia might take damage by incentives such as smoke or infections. First, often only the power is reduced. However, if harmful irritation continues, the cilia might die off. Thus, the mucus film is thickened increasingly in the glands. The slime film thickens and cannot properly be removed, if additionally surfactant disorders are appearing. Increased secretions. In this way, the mucus in the bronchi accumulates and narrows the bronchi. Not to suffocate, the mucus must be coughed up. In order to really be able to cough up, the bronchial tubes in the cell area and the coughing mechanism must be intact. Cough reflex. Along the bronchial mucosa into the smallest bronchioles, there are cough receptors located, marked in pink. These receptors are irritated by increased and thickened mucus, which is bad to be transported. They send nerve impulses through the spinal cord to the brain into the cough center of the medulla oblongata. The cough center gives a pulse to the inspiratory muscles, the larynx muscles, and to the glottis. Hereby, we breathe deeply and thereby close the vocal cords. So the pent-up air from the lower respiratory tract, including debris and excess mucus, can escape explosively by a sudden opening of the glottis. Essential for the cough reflex are intact respiratory muscles, a normal work of the cough receptors, and nerve conductions, as well as an intact closing mechanism of the vocal cords. Clinical pictures. At the normal cough, it is inhaled deeply. The larynx is closed and a high pressure is now rebuilt with the preloaded muscles in a healthy person of about 100 cm H2O. By opening the vocal cords quickly, the pressure inside the bronchi is released and the airflow pulls mucus and other particles with it. Cough operation. During the deep inhalation required for the cough, bronchi are extended through the elastic stretching in the bronchial tree and narrowed by a decrease in the volume of the lungs during exhalation. This elastic stretching of the bronchi keeps them open in spite of high pressure at the beginning of the cough. Tracheal instability. The front and side of the trachea is stabilized by U-shaped cartilage, grayed out. The back wall of the trachea consists of a membrane and some muscle. The high pressure does not compress the cartilage, but impresses the back wall of the trachea and its mucous membrane with its cough receptors. The rear tracheal membrane can lose stability by long cough, mucosal weaknesses, operations in the tracheal area, etc. The air can no longer escape the coughing from the bronchial tubes. One speaks of a bronchial collapse. The tension which keeps the bronchial tubes open stops massively with respect to smokers, COPD patients, and also asthmatics. Thus, the bronchi are both at the normal exhalation as well as during cough effectiveness, narrowed or even closed. In addition, there is often an increased amount of mucus, as well as damage of the cilia. It is easy to understand that the removal of mucus is difficult. Collateral ventilation. Through the closure of the bronchus with mucus, we have a missing ventilation of the underlying pulmonary section. This is called Atelectasis. The bronchial tree has the so-called collateral ventilation bypass connections. Under normal circumstances, those connections are closed. However, in case of a closure, it could result in an alveolar ventilation bypassing the normal respiratory tracts. This aeration can be inter-alveolar, bronchial alveolar, interbronchiolar, and interlobar. The opening of these compounds are required depending on the clinical picture, between 10 and 30 cm H2O. The drawing shows that no air enters into the right bronchus through the closed bronchus, yellow shown, and you can recognize how it is evacuated, forming an atelectasis. By pressing on the left bronchus, the collaterals open, shown in blue. The air can enter through the left bronchus in the right. So, the mucus is pushed from back to front towards the trachea and mouth. Physical therapy, RC-Cornet, position 1. A so-called combined positive expiratory pressure, combined PEP, is produced by breathing through the RC-Cornet in position 1. This is a continuous positive pressure which is overlaid by pressure fluctuations. Green representation in the double oscilloscope and the yellow appearance shows the resulting flow variations. Due to the continuous positive pressure, the bronchial tubes are pressed apart during exhalation. The air that otherwise could not escape through the collapse of the bronchi can flow to the outside. Unstable bronchi are stabilized. The pressures which are necessary for the opening of collateral ventilation can be achieved. The pressure fluctuations also activate the surface active substance, surfactant. This facilitates the removal of mucus and stabilizes the alveoli. The additional pressure fluctuations applied to the continuous positive pressure lead to the fact that the mucus dissolves from the bronchial walls. Flow fluctuations transport it to the outside, stop-and-go phenomenon. Physical therapy RC-Cornet, position 4. In position 3 and 4, the valve hose in the RC-Cornet revolves around its own axis. The pressure rises from 0 to a maximum and then suddenly drops off. In this position, the valve hose must overcome significant friction. Therefore, the pressure increase is slow, but the pressure drop is abrupt. See also the double oscilloscope recording. Green, the gradual increase of pressure followed by a sudden drop-in. The pressure and flow fluctuations, shown in yellow, are transferred into the bronchial system and lead to a gradual extension of the bronchi. This allows the mucus to reshape itself, followed by a sudden pulling together of the bronchi. The bronchial mucus does not have time to deform and is thus transported towards the mouth. High-frequency 120 cycles of oscillations stemming from the free end of the hose are also shown on the oscilloscope display. Higher frequency, 100 and more cycles, is known to reduce breathlessness, dyspnea. The positions 3 and 4 of the RC-Cornet are applied to patients with mucus problems, cystic fibrosis, bronchiectasis, acute exacerbations of chronic bronchitis, and asthma bronchial. The positions 1 and 2 are applied for patients with tracheal bronchial instabilities and emphysema. If the mouthpiece of the RC-Cornet is pulled out of the curved tube by 2 cm, the pressure drops to around 5 cm H2O, at which the device starts to swing. So the tool can also be used by seriously ill patients on weaning to strengthen the respiratory muscles.